It's certainly a great pleasure to be here, and I feel extremely privileged to talk to you about our exciting project. So, I have nothing to disclose. As we all know, LabColi soon became the standard of care, only like in a matter of 5 to 6 years after its first introduction in 1985. However, we still continue to see problems, devastating complications such as bile duct injuries leading to liver resections, or even liver transplantations. And actually, we're not helping much. The problem that we have to think about is that why don't these surgeons recognize that they're in danger? In other words, why don't they recognize that they're in a difficult situation? So it's all about difficulty. So let's take a look from a different perspective. So we have this international guidelines, and we have very good clinical questions. And basically, the idea is to set safety for patients. But again, we don't have enough evidence here. So we all favor early over delayed LabColi. But again, there's no clear definition of early or delayed. And how about optimal time for conversion? We just talked about conversion. But again, level C evidence. And how about PTGVDs? No evidence whatsoever. And now we have this SAGE's Safe Cholecystectomy program. And I always tell my junior surgeons to take a look at all these 6 items, which are all great. And the last one, it says, get help from another surgeon when the dissection or condition are difficult. Again, what's difficult? All right, so probably people will say that you just have to use your common sense. But again, it's not helping the patients, so we have to do something about this. So why is difficulty difficult? Because there's no definition, and that's a problem. So we thought that why don't we just do it? So we met up, and our topic was that we have to think about is defining the surgical difficulties of laparoscopic cholecystectomy based solely on intraoperative findings. We thought that this might be one change, and these are all the members of our Japan-Korea-Taiwan collaborative project, and so far we've published 3 studies, and I'm going to go quickly about what we've found so far. So I'm going to skip the first preliminary survey because this large-scale survey is the one to validate what we found in the preliminary survey. So we asked for over 500 surgeons to join this survey, and actually we had a very good response rate of over 90%. And we set the cutoff of, when we say expert LC LabColi surgeons, to have lifetime cases of over 200. So we had 2 sets of questions. One is, how do you see your LabColi yourself? What do you think about your length of surgery, blood loss, and other types of commonly used procedures, LC-related, LabColi-related procedures? And the other set of questions were about intraoperative findings that you see during LabColi, and we wanted all the surgeons to grade all those findings in a scale of from 0 to 6. So that means in a scale of it's going to be a 7-stage scale. So starting from the first one, this is an example of the actual questions. What is the maximum duration of surgery for LabColi that your center would accept? As you can see, there's significant difference. There's no agreement whatsoever. And so when we did this analysis, duration of surgery, estimated blood loss, there's no agreement. So they can't be common indicators of surgical difficulty. And how about all those common procedures that you use every day? And probably, so this is, it's really center dependent. Intraoperative cholangiogram, critical view of safety, checking the Rouvier sulcus, SSA, you might not be aware of this term, but this is something we commonly use in Japan, at least. Again, they're all significant. There was significant difference in all of these 4 items, and we even stratified according to the experience, their lifetime experience LabColi cases, and the difference was still there. So again, these we see that the procedures are not standardized at the moment. And now that this relates with the previous talk, So when do you convert to open cholecystectomy? Thank God there was only one clinical scenario that most of the surgeons agreed. When you see damage to nearby organs, or if you find bile duct injury, that's the time you open. Well, that's understandable. But all the others, extensive surgery, blood loss, adhesion, fibrosis, scarring, some people care, some people don't. So open conversion rate, that's not the indicator for the difficulty of lab chole. So is there anything left? Well, there's still hope, and we know that. So when we think about intraoperative findings, so this is what we got. So as you can see, this box and whisker diagram tells us that the surgeons agreed that as the fibrosis changes, scarring develop or gets worse, most of the surgeons agree that the case is going to be difficult. So when we feel we're in trouble, that means the gallbladder has some inflammation. Now, and how about other findings? Obviously, if you see abscess formation or fistula from between the gallbladder and the bowel or to the common bowel duct, you're in trouble. And also we ask questions about other factors as well. And these are the agreement rate that we got. So we thought, and well, we probably need to dig in a little further. So we decided to conduct a Adelphi study on this. So these two are the criteria that we set to say that we reached a consensus. So we did the second round, including all these surgeons, over 500 surgeons in East Asia. And thankfully, all the 25 intraoperative findings reached Delphi consensus. So we have a good agreement here. And then we thought about what we should do from here. So it's obviously not the end, not even close. So to establish a novel grading system of surgical difficulty, we have to have a clear, simple, and consistent word to set surgical difficulty. So these two factors that can cause large variability, measurement error, which is inherent to any kinds of studies, and confirmation bias. If you know the patient beforehand, you kind of bias yourself. So we decided to adopt this central review. This methodology is commonly used in chemotherapeutic trials. And what we're going to do with this is that we need to assure objectivity, and this is all what it's all about. So we have this protocol. I'm not going in too far, but we're going to check all the surgical videos. We have the local surgeon who operates on their patients evaluate their own, and then we have the central reviewers who are completely blinded to all patient, surgeon, and center informations. And then we're going to calculate the agreement level between the local surgeon and central reviewers. Okay, so this is kappa statistics, as you probably all know this. And this is a snapshot of how we're going to do this. We're going to invite a lot of hospitals, and then we're going to check. We're going to send them to. We're going to invite some of the cases to submit videos, and then we're going to do the blinded central review. Actually, we did the pilot study already, and this is to show you what kind of agreement rate we saw. So this is a pilot study of 13 cases, and you can see those black dots lining nicely in most of the items, which obviously now we're seeing an agreement between the reviewers and the surgeons. One more minute. Okay, thank you. So we have a little more work to do. How are we going to finalize the score? So obviously, all the evaluation sheet will come in the raw scores, and we tried 3 patterns, and it looks like the third one was the best. It's almost like similar to the Child-Pugh score. So if the total score is over 8, and you also have to have the highest score above 4, then you have the highest surgical difficulty grade. So from now on, what are we going to do? We have to determine the best scoring method. So we have to pile up more cases in order to finalize our evaluation system. And then the validation of the evaluation sheet, we have to have a large sample size. And at the end, we're going to have this novel grading system on surgical difficulty during lab chole. So this study is very unique. This is going to be the first study to establish an international criteria of a surgical procedure using a common language. We're going to use the same rule in different countries. And we're also going to use this central review methodology using surgical videos, and I haven't seen anything like this before. And obviously, this is not just about East Asia. We really need to strive to consolidate all the global efforts. Thanks for SAGES for the Safe Cholecystectomy program. We have to have this global effort going on to eradicate all the devastating complications. Thank you so much for your attention.
That was very exhaustive, very good. Do we have any questions from the audience?
Thank you very much. This was a really tremendous effort to try to at least harmonize or some cohesiveness. First question, one question. In Japan, before we go to Korea and Taiwan, are you all doing the same things? Are you all following certain criteria? Before you followed.
Actually, what we found out was that we're doing things so much differently. So that was what we found. That was what we find. So now we're thinking we probably need. We thought we've already standardized our protocols and the way we do lab choles, but actually, in fact, it was not the case. So that's what we need to move on. Yes, we probably need to think about, for example, about critical field safety. Everybody says CVS is important, but if you go too far, trying to find CVS itself can cause problem. So those are probably the area that we need to look into.
Thank you very much. Thank you.
Thank you.